Thank you, Gordon. We could have the slides on, please. I'd like to start out first by talking about computed tomography of the chest wall and pleura. And I think any of you who have looked at any chest CT scans will realize that we can get very nice images of abnormalities of the pleura and the chest wall. In fact, generally much better than on conventional radiographs, particularly because of the cross-sectional display that we're utilizing. But I think a totally separate issue that we really don't deal with often enough is, does this help us a lot? I think CT is not often making specific diagnoses of diseases of the chest wall and pleura, and many of these abnormalities are either easily seen on conventional radiographs, typically with pleural abnormalities, and then easily aspirated or biopsied, or alternatively even palpable, because chest wall lesions are often very accessible to physical examination. So what I'd really like to do with this talk is try to examine some common clinical problems that relate to the chest wall and pleura, try to give you some guidelines of when CT in fact really is playing an important role rather than just when it's giving you pretty pictures. I think the first situation we encounter relatively frequently is you've got a lesion on a chest radiograph and you're trying to sort out whether it's in the parenchyma of the lung, whether it's a pleural lesion or else extrapleural. This is sometimes a problem. I've picked out a few specific situations that apply to this. The first is whether you're dealing with an empyema or a lung abscess. And this is a very important distinction because the clinical treatment that you're going to give to a patient will be markedly different if you think somebody's got abnormality, infection in the pleural space that's going to require drainage and a more aggressive approach. If you think somebody's got a lung abscess, you're much more likely to attempt to get by with antibiotic therapy, percussion and postural drainage, and so on. So this is a very important distinction. It is one that can be made in a large number of cases just using plain chest radiographs. And I think you're probably all familiar with the chest radiographic criteria that have evolved over the years, which include, first of all, the angle that a lesion makes with the chest wall. It tends to have an acute angle if it's a lung abscess because lung is nearly completely surrounding it, whereas it tends to have an obtuse or a right angle for an empyema, typical of a pleural or extrapleural lesion. Shape of the lesion is also important. Lung abscesses, as with most parenchymal abnormalities in the lung, tend to grow in a relatively concentric fashion and therefore to be pretty much round, whereas empyemas tend to assume the space that are allowed to them, and therefore they tend to be relatively lenticular in shape. And as a corollary of that, if you look at a lesion on right angle views, if it's round like a lung abscess, it's going to be about the same size on each view. If, on the other hand, it's lenticular, on one right angle view, it tends to be quite large, and on the right angle view to that, it tends to be much, much smaller. Now, CT can also use these exact same criteria, and in some cases can see the specifics much more easily. For example, angle of contact with the chest wall and shape of the lesion are often very well seen. Here's a very nice acute angle on both sides, typical then of a lung lesion, a lung abscess. But I will point out that although you're seeing some of these things very well, on any individual axial image you can be fooled. A lesion that looks lenticular, when you really sum up what it looks like on a single axial image, may well look like it's round. So you have to think three-dimensionally. You have to look at the whole scan, not at any single level. And one other problem we've seen a lot of times is that although this is very nice because you have the same angle here as you have there, and similarly, you have the same angle here as you have here, which was more of an obtuse angle, typical of a pleural abnormality. We've seen a number of cases with one acute angle and one obtuse angle. And the question is, what do you do with that? This one turns out to be an empyema, but it's not always so clear-cut. So some more specific CT criteria have been developed to try to help you with this differential diagnosis. And the first is that you cannot appreciate wall characteristics in many cases with conventional radiographs, but with CT that's often quite easy. Lung abscesses tend to have thick, irregular walls, whereas empyemas tend to have very thin, smooth, regular walls. And here, contrasting two cases then, the case on the left showing a very thick, irregular wall, typical of a lung abscess. The case on the right actually demonstrating bilateral empyemas with nearly imperceptible walls. Another important sign that you can use with CT that also is hard to demonstrate with conventional radiographs is compression of adjacent lung, because pleural processes such as empyema tend to act as space-occupying lesions and to push the lung out of the way. Lung abscesses tend to destroy the lung that's in their path, and so where there is lung abscess, the lung is destroyed, but adjacent to it, the lung tends to remain completely normal. So this would be a typical example of a large lesion in the right hemithorax with clear-cut deviation of some of these vessels and bronchi. That would be typical of an empyema. And as opposed to that, a reasonably similar lesion in the right posterior hemithorax, rather large, not as large as the one that I just showed, But if you notice, the blood vessels go right up to this thing and are not pushed out of the way at all. This then would be much more typical of a lung abscess, which in fact it represented. A final sign that's been described as the split pleura sign. The rationale for this is that if you can demonstrate the visceral and parietal pleura separating around a lesion, then if the lesion is in between them, it must be a pleural process. In order to use this sign, you have to give bolus intravenous contrast to be able to enhance the pleura. But if you can, in fact, demonstrate that split pleura sign, as in this case, that would be pretty typical of an empyema. Does not tend to occur with lung abscesses. The first series of patients that were evaluated using this combination of criteria came, in fact, from UCSF, published back in 1983. And in that initial series of 58 empyemas and 12 lung abscesses and a total of 63 patients, CT was 100% accurate. I think if you talk to the authors, they acknowledge that they didn't expect it to be 100% accurate. They don't necessarily feel it's 100% accurate in real life, but it's at least close to that. It's certainly over 90% accurate in evaluation of these different signs. One thing that's been pointed out in the literature much more recently, in 1987, by Dave Nadich's group in New York, is that if you have fluid in either bulli or lung cysts, they may very closely simulate pleural disease in just about every way you can imagine. So I think it's pretty clear that no sign or combination of signs is going to be 100% accurate. But again, I think CT gets reasonably close to that. This is an example from their article in JCAT, just to show you that you've got something that looks like it's discrepant in size. It's much longer in lenticular shape, much bigger on the lateral view than it was on the PA view. The angles tend to be obtuse, and it even looks like there's a split pleura sign, and yet this turned out to be a parenchymal abnormality, a big pre-existing lung cyst that got infected and filled up with fluid. So you should be aware of this pitfall. Now, another situation that we encounter sometimes with CT is that you have some simulators of pleural disease. We've seen this in two general categories. One is parenchymal lung abnormalities that look like they might be pleural, and another is subdiaphragmatic processes, that is, for example, diaphragmatic hernia with liver sticking up into the chest, in some cases looking very much like a pleural abnormality. In our experience with these different entities, we find bolus dynamic CT very helpful, because if you demonstrate vessels throughout an area of abnormality, that's not going to be typical of a pleural abnormality, and instead it suggests one of these other processes. Here's one such example. We had a patient with abnormality at the base of the right hemithorax. Not very clear from the PA and lateral whether this was going to be pleural or not pleural. I think we were, in general, leaning toward a pleural abnormality. The patient initially had an outside CT scan without bolus intravenous contrast, and the abnormality looked relatively homogeneous. So again, I think the betting was that it was probably going to turn out to be pleural, until we gave a good bolus of IV contrast, saw vessels all the way throughout, suggested instead that it must be a parenchymal lung abnormality, and this turned out to be alveolar cell carcinoma. Of course, it's only fair if parenchymal processes can simulate pleural processes that the converse should be true too. And we've seen several examples of pleural abnormalities such as this that look for all the world like a parenchymal abnormality. This nodule, not real well seen on the plain film, was much better seen at CT. Looks to be round, sharp, smoothly defined, very typical of what we expected to be a lung nodule, until somebody noticed that it was right in the expected location of the major fissure. And once you realize that it's near a fissure, then it raises another possibility, that is that it's a pleural lesion in the fissure. This, of course, is very important, because if you start out with somebody who you think has a solitary lung nodule, the odds are you're thinking about bronchogenic carcinoma. If you start out instead with a discrete, well-defined nodule in the pleura, the odds are much more that this is going to be a benign pleural lesion, such as a benign fibrous mesothelioma, and in fact, that's what this proves to be. Now, of course, most fibrous mesotheliomas are going to arise at the periphery of the chest, and they're going to have relatively typical appearances as pleural masses. But if you put one such mesothelioma into a fissure, as I say, it will be surrounded by a lung, and it will clearly simulate a lung nodule in just about every way. If you're aware of this possibility, you can sometimes get the jump on the diagnosis, as we did in this case. Had another lesion that on plain films and the first CT scan looked like it was going to be a parenchymal lung abnormality, but we noticed that it was again in the region of the fissure, went back and got 1.5 millimeter thick sections at 1.5 millimeter intervals, and we could see that it's actually sitting right in the middle of the fissure. This was also a benign fibrous mesothelioma. Finally, I'd like to conclude this portion with a consideration of incidentally detected juxtadiaphragmatic fluid, because it's very clear that we do CT for many reasons other than for pleural and chest wall abnormalities, but we sometimes detect unsuspected juxtadiaphragmatic fluid and its localization is very important for differential diagnosis. There are CT criteria that have been developed. I'd like to go through them one at a time. First is lateral displacement of the cruce. That was the very first one described, and what it states basically is that if you have fluid that is pushing the diaphragmatic cruce laterally, that has to be pleural fluid, whereas if you have peritoneal or even retroperitoneal intra-abdominal fluid present adjacent to a cruce, the cruce will not be pushed laterally. So this, for example, must be pleural fluid because it's pushing the cruce. Second sign relates to the hemidiaphragm. That is, if you can see the ipsilateral hemidiaphragm, as you do here, a curvilinear structure, when you have fluid along the outside of it, peripheral to it, that's pleural fluid, and the fluid that's central to it in here has to be in the abdomen. And this is just a consequence of what it's like to get transverse images through a curved structure. Of course, the diaphragm normally is convex upward, and so as you cut across it, anything along the inside of it is in the abdomen, anything along the outside of it is in the chest. A sign described by a group in Philadelphia at Hahnemann University is the fluid-liver interface, and I think you can extend that also to talk about the fluid-spleen interface. When you have fluid up against the liver or spleen and it's very sharply outlining the liver or spleen, that tends to be intra-abdominal fluid. You can have pleural fluid that comes close to the liver, but it will generally have a fuzzy interface with the liver, and the reason is that although you may have a hard time imaging it, you've got the hemidiaphragm curving through the plane of section, and so in fact the fluid is not really right up next to the liver. And so I think this liver fluid interface sign is a relatively useful sign. Finally, just as a rough rule of thumb, if you just talk about where the fluid distributes, you've got a pretty good way to make a guess whether you're dealing with fluid in the chest or fluid in the abdomen. Particularly in the right upper quadrant, it's very clear that fluid never reaches the farthest posteromedial aspect of the right upper quadrant, and that's because of the bare area of the liver. There's a retroperitoneal space there, not an intraperitoneal space. So intraperitoneal fluid tends to get to about this point, as it has here, and then to progress no further posteromedially. Certainly when you see fluid all the way back in the posteromedial aspect of an upper quadrant, it's almost certainly pleural. Now this is an absolute indicator in the right upper quadrant. It is only a relative indicator in the left upper quadrant because there's not exactly a bare area of the spleen. Once in a while, fluid will track around posteromedial to the spleen, and so occasionally when there is massive intraperitoneal fluid, you can have a relatively posteromedial location in the left upper quadrant. However, there are some relative obstructions to fluid moving around that way, not the least of which is the spleen itself, which usually blocks fluid, keeps it anterolateral the way it does in the right upper quadrant. So I think that this is also a reasonably helpful sign. Certainly the combination of these signs will usually allow you to make the distinction of whether fluid is in the chest or in the abdomen. There are pitfalls with this, though, as with almost any CT sign you can think of, that ought to be acknowledged. The first is that if you have atelectasis coexisting with subpulmonic fluid, it may well simulate a hemidiaphragm, as it seems to do here. If you thought that this was a hemidiaphragm, then you would expect that to be pleural, but that to be intraperitoneal fluid. In fact, this is just atelectatic lung with pleural fluid on both sides. There's no intraperitoneal fluid here, and the shape is usually a little bit different. Usually with serial sections, you'll be able to identify little areas of air bronchograms or high attenuation typical of lung to help you sort out a hemidiaphragm from a little bit of atelectatic lung, but it is something to pay attention to. Now, if you have enough pleural fluid, you will often cause inversion of the hemidiaphragm, so that instead of being convex upward, the hemidiaphragm will be convex downward. And in this case, the relationships are reversed. If you have fluid inside of an inverted hemidiaphragm, that's pleural, not abdominal. And alternatively, if the fluid is peripheral, it's going to turn out to be peritoneal. So this is something to be aware of as well, and I want to thank Dr. Halverson, who's now at University of Minnesota, for lending me this slide. Clearly, loculated fluid will also give you problems, not so much in a case like this where we're clearly away from the diaphragm, so it's no problem to know that this must be loculated pleural fluid rather than abdominal fluid. But if you get down near the hemidiaphragm, in some cases it will be very tricky to try to sort out whether you're dealing with loculated pleural fluid or some abnormality in the abdomen. And in cases like this, sometimes it's helpful to get more cranial or more caudal scans. Sometimes it's useful to do decubitus scans. I think if there's any real issue as to what you're dealing with, ultrasonography is probably the way to go, because the ability to image in the sagittal plane is often all you need to determine. All you have to do is find the hemidiaphragm and decide based on that whether the fluid's in the chest or the abdomen. Now, the other major situation that we often deal with, and probably this is true of anybody doing CT, is you've got a patient with cancer, and you need to know what is the full extent of malignant disease, or in fact, whether there is malignant disease at the time that you're scanning the patient. And with regard to the pleura and the chest wall, there are a few situations I'd like to highlight. The first is a patient who's post-pneumonectomy. Here is one place where I would really give CT a ringing endorsement as a very important tool, because the problem with the post-pneumonectomy space is there's almost no other way to visualize it. Certainly routine radiographs, tomography, or bronchoscopy will leave you with major blind spots. So if you use CT, I think you're going to end up doing a much better job of following up patients who have had pneumonectomies. After a patient's had pneumonectomy, the normal space tends to be homogeneous and low attenuation. I'll illustrate this in just a moment, and tends to have a concave medial margin. As opposed to that, when you have recurrent tumor, it tends to give you central non-enhancing soft tissue as opposed to the central blood vessels, or else out in the periphery of the post-pneumonectomy space, instead of the usual low attenuation appearance, you'll get higher attenuation foci. These are two different cuts from a patient who's normal post-pneumonectomy, and as I've mentioned, the space tends to be relatively homogeneous, low attenuation, and concave along its medial margins. Where the surgical clips are, you can see there is no excess soft tissue, and everything on this scan in the central region is enhancing pretty well, typical of left and right pulmonary artery. As opposed to that, two different patients who have recurrent tumor after pneumonectomy, the first illustrated here, showing a large central focus of abnormality that is just not enhancing. There's no clear-cut explanation for what this should represent, and therefore it ought to be considered, until proven otherwise, to represent recurrent tumor. Alternatively, a different patient looking out in the space itself, noticing that there are large islands of higher attenuation tissue that just don't belong in a normal post-pneumonectomy CT. This also represents recurrent tumor. Now, I should point out that if you're going to do post-pneumonectomy CT, technique becomes very important. I think you really need dynamic incremental scanning with good bolus intravenous administration of contrast, because you really need to be able to sort out the normal vessels centrally from the adjacent soft tissue that might represent recurrent tumor. And I would also like to point out with this application, and even going back to something like empyema versus lung abscess, that CT is not tissue specific. It's not making diagnoses such as this is an empyema or this is recurrent tumor. What it's doing for you is identifying abnormality, giving you an idea where the abnormality is located, whether it's pleural or parenchymal, and telling you you probably ought to go after this to get some sort of other confirmation to indicate the presence of tumor or the presence of infection. So it's not specific, but it does show you where the abnormality is and guide you to what needs to be sampled. Now, another situation we can look at is a variety of pleural tumors, in particular malignant mesothelioma, but also pleural metastatic disease and benign pleural neoplasms. CT generally shows malignant mesothelioma to be just what you'd expect it to be from your experience with plain radiographs. It's a diffuse multilobular soft tissue mass, but these are things that are almost always pretty well seen at conventional radiography as well. And again, as with all these other things we've talked about, final diagnosis really still relies on microscopic examination of tumor. So here's a typical example of somebody with diffuse left pleural abnormality, kind of lobular along the margins, relative decrease in volume of the left hemithorax, which is also typical of mesothelioma. It tends to fix the hemithorax. I think from this film alone, one would be quite suspicious that the patient had malignant mesothelioma. And I think the CT just kind of gilds the lily. It demonstrates the irregular lobular soft tissue along the pleural margin. It does also show you some calcification, which was not easily appreciated on the plain film, so maybe that gives you a little bit more evidence that this is a patient with asbestos exposure and mesothelioma. It also allows you to demonstrate some of the associated pleural fluid. But again, my question for you would be, did this really make a contribution in this case? I really don't think so, at least from the standpoint of diagnosis. Now, other people have said, all right, I can diagnose mesothelioma pretty well from plain films, but I still think CT should have a role because it's much better at staging mesothelioma. And this is clearly an argument we use in all sorts of tumors, because as time has gone by, we found CT can be a good staging tool, for example, for bronchogenic carcinoma. Well, I have a couple of problems with using CT to stage malignant mesothelioma. The first is that we've had several experiences where we actually underestimated the full extent of tumor because some areas that we thought were pleural fluid turned out really to be tumor at the time the patient had surgery. So that's one problem. And then the second problem is that right now, I believe that the prognosis of mesothelioma is so poor no matter what the therapy that I'm not sure why it's important to stage it accurately. I mean, obviously we always like to be accurate, But if we're being accurate to no good purpose, then again, I don't think we're making a real contribution. Benign pleural neoplasms, I've already mentioned to some extent when I showed you some fibrous mesotheliomas. I think CT is clearly good at demonstrating these tumors, but that doesn't mean it's an important diagnostic tool, because even after you've demonstrated the lesion, they almost always are going to have to be removed. The one exception I would point out that where CT really plays a role is when you've got a pleural lipoma. Of course, this is a pretty rare situation, but if you have a pleural mass and you do a CT scan and you find that it's just completely composed of fat, like this one is, just like the subcutaneous fat, then you can leave that one alone. That's a pleural lipoma. That's the end of the story. Pleural metastases are probably the most common pleural tumor we deal with, and the usual finding we get in patients with pleural metastases is just pleural effusion. Generally a non-specific pleural effusion, nothing that would distinguish it, at least by CT, from the pleural effusion of congestive heart failure or any other pleural effusion you can think of. So the real way that you've got to make the diagnosis in most of these cases is by thoracentesis and or cope needle biopsy. But once in a while, if you see nodular implants along the pleural surface, as you can see here, for example, with soft tissue foci, this would make you very strongly suspicious of metastatic disease. And certainly if the initial thoracentesis or biopsy had been negative, you might want to press on and suggest repeat the sampling, because this would be highly suspicious. Now, in this same patient who did have pleural metastatic disease, I have a lower down cut showing these big foci of tumor, and I want to contrast that to another patient who I think has a very similar appearance. We saw this patient recently and said that this must be pleural metastatic disease, although interestingly the patient wasn't being evaluated because of a history of tumor, just because of this chronic pleural effusion, and they sampled it a number of times, never got any tumor out. Over the course of a year it went away. Clinically their impression was that this was a big pleural hemorrhage, and these were probably just areas of clot sitting in the pleura. So one thing that's been suggested to me by other people who have seen this case is sometimes when you see something like this, you might want to consider getting decubitus scans, because the implants of pleural metastatic disease are not going to move around. Large blood clots may well flop from side to side when you change the position of the scanning. Chest wall invasion by lung cancer is one last topic in this area that I'd like to discuss. Chest wall invasion, it's important to point out, no longer determines resectability. When chest wall invasion is present, it is still possible to resect lung cancer and to locally resect the chest wall, construct a chest wall prosthesis. So it is important to point out you're not talking about resectable versus non-resectable, but you are talking about surgery that has higher morbidity and mortality. So it would be nice to be able to alert a thoracic surgeon ahead of time that this might be a case where chest wall invasion were present. And we looked at a number of CT criteria. This has subsequently been done by other groups, including the group at Mallinckrodt. I think everybody's come to pretty much the same conclusion. First of all, we looked at the angle of contact with a lesion, assuming that if you had acute angles, for example, that would imply that a peripheral tumor was limited to the lung parenchyma and not invading the pleura or chest wall. And in this case, here are the islands of foci of tumor that are extending into the pleura and chest wall. So angle of contact is not useful at all. It really does not separate patients with disease limited to the lung from those with chest wall invasion. Now, one thing we found to be quite sensitive is the presence of adjacent pleural thickening. That is, if there was going to be chest wall invasion, just about everybody would have some adjacent pleural thickening. Unfortunately, this sign is not specific. There are a lot of other patients who have adjacent pleural thickening who do not have chest wall invasion. Here's one such patient with lots of adjacent pleural thickening adjacent to this large peripheral lesion. Turns out to have no chest wall invasion. Another patient with adjacent pleural thickening who does have chest wall invasion. So it's sensitive but not specific. There were signs that were specific. These included encroached upon or high attenuation extrapleural fat, asymmetric soft tissues, apparent chest wall mass, and rib destruction. But these were not at all sensitive. There were many patients who had chest wall invasion without these signs, and so it was not a particularly useful screening tool. And in fact, it's sort of ironic, focal chest pain is probably more specific than any combination of CT signs, so who needs that big expensive test? In our own experience, it's probably better to be sensitive but non-specific in order to be able to say this is a case where you might have to do chest wall resection rather than to miss such a case. And so when we see adjacent pleural thickening, we raise the possibility of adjacent chest wall invasion, but we make it very clear to the surgeon that this is not for sure. I'd like to conclude now by just giving you some summaries of some other things that I feel about the use of CT in the region of the chest wall and pleura, including some areas that we really haven't had time to cover in depth. I think as a general rule, you could put in the very useful category for CT, one, localizing lesions, as we've pointed out, evaluating the post-pneumonectomy space, looking at the brachial plexus to try to separate out idiopathic plexopathy from tumor involving the plexus, although MR may well replace CT for this indication. And finally, examining the sternum. I don't think there's any other particularly good way to look at the sternum. I think CT is somewhat useful for differentiating empyema and lung abscess, with the limitation that many of these cases can be differentiated just based on conventional radiographs, in distinguishing pleural disease from its simulators, although I think that's a relatively uncommon situation, and then in diagnosing the vascular nature of certain lesions. For example, AVMs or hemangiomas are easily diagnosed with CT in many cases because they're so vascular. CT is occasionally useful for diagnosing pleural lipoma, but as I've mentioned, that's a rare tumor. And once in a while, when you have chronic pleural effusion, if you can demonstrate nodular implants, as I've shown you, or subpleural cavitary lung disease that might indicate the presence of tuberculosis that has resisted diagnosis to date, you may be able to have your clinicians press on, make more effort to come up with a final diagnosis. But in my own experience, I think CT is rarely, if ever, helpful or indicated in patients with either malignant mesothelioma or peripheral lung cancers where you're trying to determine chest wall invasion. Thank you very much.